Dr. Salman Arain, who does not need any introduction. We all know him very well, and he's been a great resource on our WhatsApp group and recently came to Park Live as well. Always very helpful and supportive of education in interventional cardiology. So he's currently Associate Professor of Medicine in Department of Cardiology and Program Director Interventional Cardiology Fellowship, McGovern School of Medicine, University of Texas in Houston. So hoping to hear from him, and we are all excited about learning from him regarding his CTO skills. And so the stage is yours, Sajur.
I don't need 5 minutes because
while is trying to get the talk going, I think we can start talking about the as the panelist, while he's trying to get the slides on indications के ऊपर कुछ discussion शुरू कर देते हैं.
I think Numan indication तो वो बात करेंगे ही. मेरा ख्याल है कि we should talk about कि program जो अगर CTO को करना है तो उसकी क्या requirement होनी चाहिए and मतलब कहाँ पे किस cath lab में ये capabilities हैं. Should it be in every cath lab? Should it be like specific people doing it who are properly trained and backup and everything?
Why don't you start with that? So why don't you start with that discussion in terms of the program जो आप raise कर रहे हैं point? So we'll start with you in terms of what program you think should be doing CTOs.
Yeah, I think obviously मैं हमेशा से ये रहा है कि एक तो ये है कि training is very very important. मतलब simple CTOs तो हम सभी कर लेते हैं, but the kind of complex CTOs या chip kind of cases जो कि सलमान करता है, those has to be done after a proper training or proctored cases. और उसके बाद जो है अब obviously retrograde तो कम हो गया है क्यों antegrade techniques इतनी बेहतर हो गई हैं, but still you need a lot of training and expertise. तो उसमें मेरा अपना ख्याल तो ये है कि हर कैथ लैब में सारे तो नहीं, एक दो लोग होने चाहिए जो कि प्रॉपर्ली ट्रेंड हों और उन्हीं को किया जाए ताकि उनका वॉल्यूम भी हो और वो एक्सपर्टीज भी बरकरार रहे. अगर एवरीवन स्टार्ट्स डूइंग इट देन इट बिकम्स रियली डिफिकल्ट. बाय तो केसेस कम होते हैं और सबकी ट्रेनिंग भी. और ऑब्वियसली आई थिंक आई एम श्योर सलमान इज गोइंग टू टॉक अबाउट इट कि जी कैथ लैब भी उसके लिए प्रिपेयर्ड होना चाहिए. मतलब स्टाफ प्रिपेयर्ड होना चाहिए, आपके पास प्रॉपर इक्विपमेंट होना चाहिए. जैसे एक कई प्रोग्राम में हमारे यहाँ भी है कि सेपरेट ट्रॉली है सीटीओ के लिए. अगर कॉम्प्लिकेशंस होती हैं तो वहाँ पे वो सारी चीजें अवेलेबल होनी चाहिए. आपको ये नहीं कि वो जब कोई कॉम्प्लिकेशन हुई है तो स्टाफ इधर उधर भाग रहा है ढूंढने के लिए कि जी कौन सी चीज कहाँ पड़ी है. तो इसलिए वो सेपरेट ट्रॉली हो और वो सारा एक प्रॉपर मतलब आई फील के प्रोग्राम के बगैर it's not that every cath lab should start doing the complex CTOs without this kind of preparations. This is what I feel.
Yeah, no, I totally agree. I think जो आपने CTO operators एक dedicated उसमें commitment उसके लिए चाहिए होती है, तो it should be for advanced interventional operators. Or having a CTO toolkit जिसपे Salman probably will touch, with your set of wires that you're used to using for CTO, वो और pericardiocentesis kit and microcatheters and गाइड सपोर्ट कैथेटर्स, वो सारी चीजें जो भी आप रख सकें जो आप रूटीन सीटों में करते हैं वो रेडिली अवेलेबल होनी चाहिए. और उसके लिए खासतौर पे टाइम कमिटमेंट और डेडिकेशन. इट्स नॉट एन एड हॉक PCI दैट यू स्टार्ट राइट अवे, प्लान करके टाइम कमिट करके. तो दैट्स द काइंड ऑफ PCI दैट यू वुड गो फॉर. तो नदीम भाई, एनी थॉट्स ऑन यू इन टर्म्स ऑफ इंडिकेशंस?
यार पाकिस्तान में मार्केट ड्रिवन इकोनॉमी है. इन एन आइडियल वर्ल्ड जो बशीर कह रहा है ठीक है, लेकिन वो टर्शरी इंस्टीट्यूट से ही लोग सीख के जाते हैं. लेकिन अगर कोई CTO अटेम्प्ट करता है और वो इनएडिक्वेटली इक्विप्ड है तो उसकी रेपुटेशन वैसे ही खराब हो जाएगी, बिकॉज ही वोंट बी एबल टू सक्सीड मोस्ट ऑफ द टाइम. तो आई थिंक पाकिस्तान में रेगुलेशन आहिस्ता आहिस्ता PSIC जिस तरह कर रहे हैं, ये डायरेक्टर कैथ लैब बनाएं और डेटा रखें, तो ऑटोमेटिकली दीज थिंग्स विल कम इनटू. जहां भी किसी को बहुत ज्यादा रोकने की कोशिश या डायरेक्ट टारगेट करो तो वहाँ होता क्या है कि एक नी जर्क रिस्पॉन्स आता है एंड देन बिकम्स अ पॉलिटिकल इशू। तो आई थिंक PSIC के थ्रू ही जिस तरह आहिस्ता आहिस्ता है, वी विल बी एबल टू गेट देयर।
Zubair साहब, any thoughts on programs and operators who should be doing CTOs? उस पे बात शुरू की थी बशीर साहब ने.
Thank you, Naman. Now you listen me.
जी जी
Yeah.
बिल्कुल.
Obviously, first of all, the indications are obviously not every CTO needs to be opened. Obviously, patient should be symptomatic, and obviously then it should be documented ischemia. और जिस तरह अभी latest Nadeem ने भी share किया था, the indications have gone the other way around. Initially, we used to open the CTO first and other multivessel lesions later on. But now, you open up with the other ones, and these are the recommendations. In our part of the world, the main thing is obviously, we all the centers can, but सबसे बड़ा इस वक्त जो economic crunch आया हमारा, that has really gone far beyond यार, उसकी वजह से जो है CTO interventions जो है financial feasibility जो है बहुत मुश्किल हो गई है। पहली बात है कि cath labs जो है properly equipped नहीं है, inventory नहीं है, I don't know how many of our cath labs, they are properly equipped with this microcatheters full range, or the wires, even the wires, Asai has the monopoly in most of the CTO interventions, or Gaias and the Confianza, they have gone to range of 30,000 plus, 35, 40,000 ki mil rahi hain, aur wo bhi nahi milti. Microcatheters, they have gone to around 80,000 to a lakh, and then guide extensions and all that, Plus stent जो आपके perfs वगैरह को address करने के लिए even you can't find even these, graft masters or papyrus, etc. in most of the cath labs, So for me, main thing is the inventory problem, the financial constraints, and obviously, otherwise, to start with, just after structural, from the public sector hospitals where you have got funding from the government side, whether it's in NICVD or PAC, etc. Obviously, they should be the centers, In the private sectors, obviously, the patient comes and bargains with you, and obviously wants 100% assurance that the CTO would be opened up, and you can't to start with tell exactly how much is the price, plus inventory. Obviously, that is the main issue. But otherwise, obviously, this is the frontier which needs to be explored in Pakistan.
Very, very valid point. Salman, are you ready to go?
Sorry. Okay. So, PCI for coronary CTOs, I think ये कैसा मौजू है जो कि it's very close to my heart. It's something I've been doing for the last 5 or 6 years. We have a pretty high volume center. Having said that, I was once a non-CTO operator. So, what does this journey mean, and what have I learned in this process, and what can I teach sort of my colleagues both here in the US and overseas? So this is a basic talk, and to the point that some people made, okay, how do you learn these things? I think you go to talks, you go to conferences, and inshallah there'll be other opportunities to discuss these things. So today's talk is more of an introduction. Okay, what's the philosophy of PCI for CTOs? Why do we do it? How do we do it? And how can you in Pakistan, sort of those of you who have an interest, dabble in it? Okay. So CTO by definition, atherosclerotic occlusion of a coronary artery for more than 3 months. We see it all the time. 20% of patients who come to the cath lab have a CTO. The many patients have asymptomatic CTOs, we don't know. So those patients who don't come to the cath lab, obviously we don't find out. And it is frequently found in patients with CABG. And there are 2 types. The first type is obviously someone who had a high-grade stenosis that became a CTO and then the graft failed. And the other type is a patient who had a CTO, was referred for bypass, and then the graft failed because it just wasn't adequate runoff in that graft. And obviously, understandably, the incidence increases with age. The reality of CTO PCI, whether you're in the US or in Pakistan, is that the rates are historically low and they vary between centers. Symptomatic patients are seldom, not referred for PCI. If there's isolated CTO, medical therapy is attempted. If there's multiple CTOs, then obviously it's sent for bypass. But if for whatever reason they're not candidates for bypass, the patient does not get to see a CTO specialist. And some of the reasons are that there's, obviously misunderstanding about CTO PCI. और ये कुछ जो आम जो लोगों की sort of ज़हन में ख्याल आते हैं कि जी success rates of CTO PCI are very low, बहुत मुश्किल है जी, हो नहीं सकता. CTO PCI is associated with high complication rates कि जी perforation हो जाती है, tamponade हो जाता है. well collateralized CTOs are unlikely to cause ischemia. जी आर्टरी बंद है तो बंद ही रहनी चाहिए क्योंकि बंदा जिंदा है चल फिर रहा है तो why try and open something up. And the absence of chest pain means कि the CTO is adequately collateralized. कि सीने में दर्द नहीं तो CTO इतना symptomatic नहीं हो सकता. And finally ये कि जी CTO जो है जो बंद होना तो बंद हो गया, इससे ज्यादा बंद क्या होगा? And therefore it doesn't need to be treated. And that's something we also hear, कि it's already closed, it can't get any worse. So there's some misconceptions, and I just want to show you a few slides okay, why this is not true in 2023. So one of the challenges we have, whether you are a CTO operator or someone who wants to refer or a patient, is that we don't have a lot of randomized data, and that's the best quality of data, partly because this is a difficult population to enroll. There's lack of standard criteria, okay, which CTO should be treated, multiple CTOs, what should be the protocol, and more importantly, questions such as, how do you determine the ischemic value of a CTO? I mean, do you do a PET scan? Do you do just EKG treadmill? How do you determine? So because of this lack of criteria and lack of studies and difficulty in enrolling patients, we don't have many randomized studies. And as one registry that looked at this said that 1,000 registries, sorry, it was one editorial that looked at this said, 1,000 registries are not worth a randomized trial. And ले दे के बात यहीं पे आ जाती है कि जी आपका randomized data क्या कहता है, फिर randomized data ना हो तो फिर बंदा अपने experience पे rely करता है, obviously registries पे. Having said that, there are 3 trials that have been attempted, they have been done. There's Explore trial with 304 patients, Decision CTO trial with 834 patients, and Euro CTO trial. So these are randomized trials that have been published. And you can see that the combined patient population is no more than 1,500, which is very small compared to contemporary trials. There is another small Russian trial also that had to do with the, nuclear sort of a ischemia on a nuclear scan with CTOs. That was also a small patient population, but that's the only 4, these are the only 4 randomized trials that I'm aware of in this area. But even with these trials, there are some conclusions we can reach. So one of the things is, if you look at these contemporary trials, the success rates vary from 77 to 91%. And something that we know is obviously depends on the complexity of the CTO that you deal with. And we have prognostication scores that can help you predict. But for patients who have an isolated CTO, especially the type of CTOs that I've seen coming from Pakistan and Pakistani patients, where the CTO is relatively young, I think you can offer success rates between 75 to 90%, which I think is a very good success rate. 1-year mortality for CTOs is similar to optimal medical therapy, is 0.8 to 2.7%. As with medical therapy, I think one of the issues is people aren't adequately treated. If you treat them, I think the mortality is low. Again, post CTO, जी आपने collaterals बंद कर दिए, collaterals नहीं खुल सकेंगे अगर MI हो गया. That's also probably a misconception because MI rates are very similar to optimal medical therapy. And there's improved quality of life at 1 and then at 5 years. So this is what we know from the randomized data, that it is no worse than medical therapy in terms of sort of the negative outcomes, and it does give benefit in quality of life over medical therapy. और उसकी वजह क्या है? उसकी वजह ये है कि not all CTOs are adequately collateralized, and this was a study done by Gerard Werner, who's been doing CTOs for a long time, even before they were sort of popular. And what he showed, he crossed lesion, he put a balloon back up, made it a CTO again, and then he measured the FFR. It turns out that even well-collateralized CTOs or CTOs that look well-collateralized tend to have an FFR which is in the ischemic zone. In fact, you can see the normal distribution. Most CTOs are between 0.3 and 0.4. And when you consider that the coronary wedge pressure is a 0.2, shows you, with the right amount of adequate amount of stress, the CTO can cause ischemia and ischemic symptoms. But the question then becomes, why don't more people complain of chest pain? And the reason for that is, the number one symptom for CTOs is actually fatigue and shortness of breath, and just lack of energy. So, this was looked at multiple trials, open CTO registry, that large registry that I showed, as well as Euro CTO. The main complaint patients have, almost everyone has dyspnea. Having said that, chest pain is not always present. And in my experience, chest pain occurs even if you're either because you're infarcting, so acute MI में आप देखते हैं chest pain हो रहा है because cell necrosis हो रहा है, inflammation है, या फिर उन लोगों के जिनके who have donor disease. So if you have a donor artery that's diseased, and that type of person who's had a CTO for many years will start having, after 5-10 years, will start having symptoms because the donor now actually has a lesion. But a CTO, an isolated CTO, which doesn't have enough collaterals, usme the typical symptom is fatigue, lack of energy, and shortness of breath. And as you can see from the Open CTO registry, that most people have a marked improvement. This is the Rose Dyspnea Scale, RDS, which is what they used. This was a large sort of quality of life component of this trial, and they found that most patients had a marked improvement in the dyspnea. And from the Euro CTO study, you can see that this decrease in angina and improvement in dyspnea and improvement quality of life is something that persisted for up to a year. And my own personal experience, I've had patients who've had literally the next day, you do the CTO, and that evening when they get up and walk, or the next day they say, सीने पे एक वजन था, वो वजन उठ गया है, you know, and पहले 2-3 दफा मैंने सुना था, I thought maybe this is something that the patient is obviously, you know, placebo effect, but you can see a change in their complexion. And truly, the large CTOs actually do have a impact on patients' quality of life. Okay, so how do you tell, okay, now you found the CTO, you have a patient who has maybe vague symptoms. Now, how do you tell if this CTO is something you should attempt or not? अच्छा, तो हमारे सेंटर में हम लोग क्या करते हैं कि हम लोग तो PET scans करते हैं because we're a large PET center, and we have basically 4 types of sort of ischemia patterns up. एक तो ischemia, your classic ischemia, okay, you have perfusion defect with stress. Then you have the hibernating myocardium, जहाँ पे it's worth doing something for that patient. Then you have infarcted, जहाँ पे there's a CTO, but then there's supplying scar tissue. Those we do not treat with the procedure. And then there are those patients who are actually well collateralized, that small segment, जहाँ पे बिल्कुल ischemia नहीं आपको नजर आता, PET pain, those also we walk away from. So, based on randomized data in 2023, why do you treat CTOs? You do it to relieve angina, you do it to relieve dyspnea, which is lifestyle limiting, as long as there's no other cause. You do it to improve EF in some patients. So there was a small study which I didn't show, post-MI patients who came in with an MI and in an RCA or circumflex, for example, and then they had an LAD CTO. If you open up that LAD CTO, you actually have 5 to 10 points of improvement in the EF. Having said that, if you open up the CTOs, you don't see that benefit, and possibly improve outcomes after ACS. However, we don't do it to improve mortality because CTO is a quality of life thing. It is not a life-saving measure, which is true for most PCI. Achha. This was an interesting study where they took unprotected left main. This is a small study, sort of a counter argument to what I've shown about mortality. And these are patients who came in for planned unprotected left main. And there's, I think, about 350 patients. This is in Italy. And they found that patients who had a residual CTO had greater mortality over the next 5 years. And most of these patients, interestingly, had an RCA total occlusion, which was often, you know, not attempted, or it was attempted, and if it failed, the patient was told medical therapy. So again, there's there may be some patient populations in which opening up the CTO can actually have mortality benefit. So there's a treatment algorithm that I think is reasonable. You have a CTO, you look for symptoms. If the patient is not symptomatic, you look at the echo, the echo if there's a hypokinesis or not. And then you can do the ischemic evaluation, but and go from there. However, if the patient does have symptoms and you see that there's hypokinesis in that area, or especially if there's wall motion that's normal, then I think it's appropriate to do CTO. Because if the patient is having chest pain, the idea is, and the theory is, that the patient must have living myocardium that's actually ischemic. Now, sometimes if there's akinesia at rest and with stress, aapko pata nahi chal raha ki ji, is this hibernating myocardium, then you can do viability. And if that area is viable, you can go ahead and do that. So we do all of this basically in one setting with the PET scans. Okay, I think Pakistan mein haspe jo aapko sahooltein hain, uske mutabik you can do nuclear scan and whatnot. But I think this is one algorithm we can use. Achha, so the group that do CTO, the big sort of conglomeration of centers here, they got together with some of their colleagues in Europe, and they came up with the principles for optimal CTO technique. And again, we won't go over all of them. I just want to say a few things. First of all, the principal indication is to improve symptoms, not for mortality. Dual coronary angiography is heavily emphasized. Structural angiographic review should be performed. आप लोग बात कर रहे थे कि setup क्या होना चाहिए. A lot of people who start off are often isolated. वो खुद ही अकेले कर रहे थे CTOs. But really, ideally, CTOs should be a group जहाँ पे there's a case review, you can discuss strategies अपने colleagues के साथ and decide कि जी हमारे पास ये equipment है भी कि नहीं ये case करने के लिए, और ये इसकी indications अगर जो है मौजू है कि नहीं, all that kind of stuff. So I think angiographic review should be part of those type of sort of hot tea meetings. Actually, use of a microcatheter is essential for guide wire support. Obviously, this is our recommendation. यहाँ के जो group था पाकिस्तान में हमने कई दफा बात की कि वो सहूलतें नहीं होती, and sometimes people say कि जी should we not try a over the wire balloon, but I think the microcatheter does have certain advantages that over the wire balloons do not. There are 4 CTO crossing strategies. This is like the ABCD of CTOs: antegrade wire escalation, antegrade dissection reentry, retrograde wire escalation, and retrograde dissection reentry. And there's actually a gradual gradation or sort of development from one to the next. So people who start off CTO should probably focus on doing antegrade wire escalation. अगर वहाँ पे CTO नाकाम हो गया है, then I think you should probably reach out to someone more experienced to see what else can you do and whether should you go to the next step or not. Change of equipment and technique increases the likelihood of success and improves the efficiency of the procedure. I think obviously this is something that it's easy for us to say in the US. I think in Pakistan, we talked about the constraints in the equipment that we have. तो यहाँ पे technique फिर आ जाती है. And obviously, as you guys know, I'd like to do a lot of Carlino. And one of the reasons I like Carlino is because I feel that the Carlino is a very cost-effective technique. आपको एक microcatheter, contrast syringe और एक या दो wires की ज़रूरत है, and you can do that as opposed to multiple re-entry devices and whatnot. So I think, this is sort of my take on the whole thing.
नहीं कोई बात नहीं. मैं यार पूछ रहा था मेरा actually
Bashir sir, please
centers performing CTOs should have necessary equipment, expertise, and experience to optimize success. I think Sohail साहब ने बात की थी. All of you agreed that not everyone should in every lab be doing CTOs. I think it's reasonable कि जिन लोगों को इन चीज का शौक है, they come up with some kind of idea. Maybe they have a CTO week. Most of these patients are stable, or maybe they can rotate centers and they इकट्ठे अपनी expertise मिला के they can review angiograms together, do these cases together. I think that's one way for the group to become strong. And then every effort should be made to optimize stent deployment in CTO PCI. I think one of the challenges is that there's a lot of disease in these patients, and if the stent is under deployed, then oftentimes these patients come back with CTO of the stent. And while a CTO is difficult to treat, an in-stent CTO is extremely difficult to treat. Acha. So basics made, there are 3 phases. There's the crossing, the vessel preparation, and definitive treatment. Today we'll focus on crossing. अगर आप cross नहीं कर पाए CTO, तो obviously आप treat भी नहीं कर सकेंगे उसे. These are the 4 techniques we talked about: antegrade wire escalation, antegrade dissection re-entry from the front, and then from the collaterals you can do dissection re-entry or wire escalation in the retrograde manner. Interestingly, इसमें भी जो है ना, it's a flavor of the month type of deal. When I train CTOs, there's a lot of emphasis on retrograde dissection re-entry. I think to the point where that's a lot of people preferred that as the first approach. Since then, we have data to suggest that this is often has higher complication rates than antegrade approaches. And so now I think a lot of the emphasis on antegrade wire escalation. And I'll be honest, for the past year, when I've started using Carlino and some of my other re-entry techniques, my retrograde has gone down to less than 5%. And just because, and with success, and not because honi para, if the antegrade doesn't work, I'll try another antegrade or do an investment. But for me to have to go retrograde, I think it's probably less than 20 patients I've done in the last year. So tools, crossing clear, their wires, microcatheters, re-entry devices, vessel prep, balloon, atherectomy devices, intravascular lithotripsy, definitive therapy, you have stents and DCBs, and obviously adjunctive tools. So we won't talk about all of them. It's something that I talked about at Pakistan Live, and inshallah, hopefully I can talk about that again next year. Like in wire selection, I think zaruri hai isme kafi, that's something you have to have, and I think the wires perform different functions. They perform cap penetration, tracking within the plaque. There's extra plaque space, septal, or epicardial crossing, knuckling, re-entry. So wires should be able to do all of these. And because there are some such specialized wires, oftentimes wires are designed for a particular purpose. Now, again, the challenge in Pakistan is economic, so you've got to choose your wires carefully, and your first wire is probably the wire that can do most, if not all of these things, and several interchanges may be required. So this is my choice, and I'd be happy to share this slide on WhatsApp. मैंने पहले भी कई लोगों ने कहा था, this is my choice for microchannel probing, cap penetration, intraplaque navigation, extraplaque navigation. अब इसमें choices तो काफी ज्यादा हैं, कुछ wires जो ऐसी हैं जो शायद पाकिस्तान में भी available ना हो इतनी openly, but I would suggest कि एक चीज नोट करने की ये है कि amongst all these choices, there are only 3 or 4 wires that show up again and again. So it's not as if I'm using 20 different wires. I'm basically using 4 or 5 wires which are available to me. And so people doing CTOs perhaps want to invest in trying to get those 4 or 5 wires. Also, it's a good idea to know uska alternative kya hai, कि कई दफा जो wire आपको चाहिए वो available नहीं होती. And again, this is one advantage कि if you do have a CTO center, या if you have a virtual CTO center जहाँ पे महीने में एक दफा, जैसे लाहौर में अगर centers ने कुछ लोगों ने करना हो, या कराची में, जहाँ पे भी आप कहेंगे जी इस महीने में दिस इज CTO वीक, और वहां पे फिर ऑपरेटर्स इकट्ठे हो जाए, तो उसका फायदा ये है कि then you can pool your resources also. Microcatheters are essential for CTO success. कई advantages over the wire balloons. The greater flexibility, they're torqueable, they can be used several times. However, sometimes if you have a hard CTO, then you need good side support, guide support. So if a microcatheter fails, it's not because the microcatheter is not good. Sometimes it's just because it just doesn't have enough support. And there's several uses of microcatheters, which inshallah in the coming few months and years, we can show cases to show that. So these are the microcatheter different types, and we use the Turnpike family here. यहाँ पे आपको तक contract से बात होती है, so हमारा hospital का contract Teleflex वालों से है, and this is their range. The Corsair has a pretty similar range, and then obviously Boston has its catheters. My personal favorite is the Turnpike LP, and I use that for perhaps 90% of my cases. Now, why I like it is because I can torque it, and I think that's a skill. Okay, I really want to do a dedicated talk on that, on torquing microcatheters, because when you have poor support, you really can't push the microcatheter. If you push it, the guide pushes back. Torquing में ये है कि at the level of the tip, the catheter drives itself forward. उसकी principle ये यहाँ पे नीचे आपको उसका structure में नजर आ रहा है. It's actually got 2 layers of nitinol coil, and so when you turn in one direction, one layer opens up and the other one closes down. So it kind of cinches the outer and inner layers, and so all the kinetic energy becomes sort of forward kinetic energy. The rotation energy becomes kinetic energy. और अगर आप दूसरे डायरेक्शन में करें तो the outer and the inner loops, they lock against each other, and then that rotational energy of them against each other pushes it forward. So जिस डायरेक्शन में भी आप इस catheter को torque करें, it tends to move forward, which I think is a brilliant design. How to get the most out of a microcatheter is adequate support. Make sure that you have the wire in the supportive part, so the wire should be advanced far enough. Alternate between clockwise and anti-clockwise motions. If you have dual braid system, do not over torque, because these catheters can actually kink, and then watch out for catheter fatigue, especially if you've been reusing your wire catheter. Achha. So the basic techniques for people who want to learn, I think this is the stages you go through. And I think stage 1 is where you spend most of your early career. So if you don't get out of stage 1 for 5 or 6 years, जहाँ पे आप सिर्फ anterior virus question कर रहे हैं, there's absolutely nothing wrong with that. Most CTOs can be done at stage पे. अच्छा, अगर वो नहीं होता, then obviously anterior dissection re-entry. And I would say stage 1 and stage 2 should be applicable for 90% of CTOs that you'll be doing in Pakistan. And I say that because they're applicable for 90% or 95% of CTOs I'm doing in the US. Some of them are very complicated CTOs. जहाँ पे retrograde via septal, I think that's an option, or bypass grafts. I think that's the best way to learn. I think the ideal way to do it is if you have a failing graft, और आपने graft को बचाने के चक्कर में अगर आपने 5 stents डालने और graft में फिर भी बंद हो जाना है, it's better to use that failing graft for a CTO and treat the native. And then obviously retrograde via epicardial. So even I have sort of gone away from doing that because I don't need to do it. So as exciting as it is to look at and do, perhaps it's also very stressful to do. I don't think it needs to be done because the complication rates are high. Asha. So we'll just show a quick case, and uske baad we can do a discussion. This is a patient with angina for 3 years. Some people may have seen this case at Pakistan Live, but I think this is a good case to discuss the strategy. Patient has a long-standing CTO. It's actually he's actually a Pakistani patient. That's what was interesting. And referring physician bhi Pakistan se tha. This is the Houston isliye. And so his referring physician sent him to me for LAD occlusion. लेकिन एंजियोग्राम जब मैंने देखा रेफरिंग सेंटर का तो ही एक्चुअली हैड अ सर्कमफ्लेक्स occlusion. मैंने उससे कहा कि जी इनके सर्कमफ्लेक्स occlusion के बारे में क्या ख्याल है? कहते नहीं नहीं ये तो कई सालों से है, तो वो तो रनेक्सा से ठीक हो रहा है. हाँ थोड़ी बहुत फटीग होती है और शॉर्टनेस ऑफ ब्रेथ, बट हैज नो चेस्ट पेन. लेकिन अब चेस्ट पेन हो रही है तो आई थिंक एलएडी का सीटीओ की जरूरत है खोलने की. सो दिस इज व्हाट वी सॉ when we did the angiogram, and this is sort of a dual injection angiography. We're just doing the right side at this point. Actually, we didn't do a dual injection because we were doing radial. So we do a radial first, and then I decide to dual karna ki nahi karna. And what you can see on the first panel is heavily calcified arteries, somewhat ectatic, and you see collaterals going to a very small portion of the LAD. Agar aap देखें LAD को, तो you can see that most of the LAD is open and the CTO is in a very small section. However, if you look at the circumflex, this is a much larger distribution. Let me play that again. You can see the circumflex is a much larger distribution along the lateral wall. And when I talked to the patient, turns out that he had actually decreased his level of exertion. He used to be a very active young man, but for the past 5-7 years, he had actually really decreased. He could no longer go for brisk walks. He would go for short walks. He said कि जी थकावट बहुत हो जाती है, सांस फूल जाता है. हाँ नेक्सा से थोड़ी बेहतरी हुई थी, लेकिन अब तो चेस्ट पेन भी हो रहा है उन्हें. And so we sent him for a PET scan, and the PET scan actually showed that he had 33% ischemia of the left ventricle, out of which 26% was actually in the circumflex, और LAD के हिस्से में सिर्फ जो है 7% था. So 7% LAD में था और जो 26% जो है वो circumflex में था. So I felt that we should try this first. So again, here's the CTO protocol which we use. This is the protocol we were taught. You look for the proximal cap ka kya hai, distal cap target kaisa hai, do you have appropriate interventional collaterals or not. So I felt that this patient did not have appropriate interventional collaterals, so we went down the antegrade approach. Lesion length less than 20 or greater than 20. This was clearly greater than 20. So we decided that antegrade wire escalation or dissection entry, we should try that. Now, interestingly, Stingray is also something I don't use a whole lot because I don't need to. So this is one of my early Carlino cases. So it was, in theory, antegrade dissection re-entry. Now, the choice of technique often depends on the age of the CTO. And again, based on my experience on WhatsApp, cases, Zabardast cases, Pakistan ke, I think most patients are towards the left of the screen. So they have CTOs of relatively short durations. अफगानिस्तान में MI हुआ या कहीं और पे हुआ ना शहर में आए second opinion के लिए. So while it's true they have a CTO, but many of these patients have CTOs that are in the process of maturing, somewhere between a few months to a few years old. And that's these sort of CTO जो पहला तस्वीर जो है where it's an organized thrombus, and then you have a microchannel, and then as you get older and older, it becomes more and more calcified. So the heavily calcified CTO where there's absolutely even no microchannel, that's rare to see, at least what I've seen in Pakistan. I'm sure they exist. So that, which is a fortunate thing. So I think the young CTO is more approachable to the antegrade. The second thing is, as you can see, the young CTO tends to be shorter in length. It tends to have more of a tapered tip going towards it. It tends to be somewhat away from bifurcation. As it matures, it becomes more and more firm on the inside. So the tapered tip becomes more blunt. Sorry, 5 minutes, take it. Becomes more blunt, and then oftentimes the bluntness ends at a side branch, and all of these things make it challenging to cross. Subinterval entry ki technique kai sari hai. You can do scratch and go, power knuckle, base, and we can talk about this. Lekin to meri the technique hai pasandida, obviously that's the Carlino, and this is what Carlino looks like. So yahan pe you use a wire to just enter the cap. Once you enter the cap, you can torque your microcatheter. Then you inject a small amount of contrast. Yahan pe you're outside. So yeah, this is what happens. So yahan pe what looked like a very long CTO ended up being a very short CTO. We have a zoomed out view of the same thing. And you can see that most of the vessel is open. So this patient who had a CTO for 7 years and fatigue was actually living with a relatively short CTO affecting very large distribution. So we went and crossed with a simple wire. This whole thing took me under 2 minutes to cross. This is just a view. So this is what we now call contrast mediated plaque modification, or contrast aided plaque modification, or CAP. which is a modification of Carlino. It creates a path of least resistance, gentle injection, which minimizes plaque disruption, so you don't go subintimal. Technique, jo hai, again, park the microcatheter adjacent to the proximal cap, inject contrast gently, and then follow the contrast stain and stop if the stain starts to go to the extra intimal space. Uska principle ye hai ki it's a sort of mixed architecture, and the contrast, gentle contrast, will find the path of least resistance and make a path for the wire. जो hard injection है दूसरे panel में है, that goes in all directions, it reflects off the calcium, and that causes more disruption and destruction, and then you end up subintimal. Or subintimal, there's nothing wrong with going subintimal, except if you go subintimal for long distances, you cut off a lot of the side branches, or for re-entry में मसला पड़ जाता है. So here you go, that was just the microcatheter. After we did the first branch, मैंने कहा जी किस्मत अच्छी, let's try the second branch, and the second branch also worked through. And you can see there are two different Carlinos here. So pehle mein to obviously we went through and through. Second mein, the contrast breaks into a side branch. And let me go back and show you the technique. Or technique usme phir ye hai ki when the contrast does that, then what you can do is you can go ahead and let me show you this. Yahan pe ye aa raha hai. So there's a contrast going to the side, and you'll see now we use a hydrophilic wire to make a knuckle and do like a mini star technique. And again, you can see how the contrast had softened that plaque for us. Ye knuckle ban raha hai iska. This is a feeler XT wire, and it pops. So interestingly, it doesn't go where the contrast went. It went into a completely different direction. And you can see this is a much larger branch yahan pe. So this was sort of our technique. And this is our final after it did. And you can see, now look at how vigorously that lateral wall is moving. You know, obviously he maybe had some component of diastolic MR, ischemic MR, but he feels great. And we haven't addressed his LAD because we haven't had to address his LAD. In fact, you can see कि OM1 से their collateral, they're going to their LAD apex. So I think he's a much happy patient. Okay. So just to show you there are some other re-entry techniques, re-entry devices. Again, this is an old case just to show you kitna purana. This is from 2016 when I was doing CTOs with this. This was in an instant, or yahan pe you can see the stent is a little underexpanded, and there's disease proximal to the stent. And us zamane mein hum log crossbars use kiya karte the. We use the crossbars. We were outside the plaque. We were able to puncture through using that re-entry device into the stent. And you can see we're using the other side to confirm. And once we did that, we angioplasty sized it appropriately. And this is our final picture. मैं आपको दिखा दूं. Oh, this is our final picture there. Okay. So in conclusion, what I'm going to say is final thoughts. Discipline of CTO PCI has grown exponentially over the past 2 decades the world over. And what is exciting to me, it is growing in Pakistan. Many tools are available. Maybe not always available in Pakistan, but definitely availability hai. There's improved success rates and lower complication rates, and a lot of this comes with experience. The CTO operator should commit to become experienced with 1 or 2 devices in each category. You don't have to know every device, just use the devices and techniques you're more comfortable with. There's several options for learning. Online tutorials hai, proctorships hai, formal training programs hai, and ultimately practice hai. Important to have tools to manage complications, and personnel know how to manage them. As with any procedure, CTO PCI should be performed appropriately for appropriate patients, appropriate indications. Just because you have CTO does not mean you should do it. And know when to stop and when to refer. And just to show you, last slide, when to stop. Agar contrast limit reach ho gaya aapka, if there's a radiation limit reach ho gayi hai, if no meaningful progress has been made in a reasonable amount of time with the technique you're trying, then do consider maybe investment procedure. And finally, if a complication occurs, sometimes that's a sign from God Almighty, it's time to stop and maybe not do anymore. And with that, that's the talk.
Should we start with question answers that we have? We have a question from Mr. Mohsen. What should be the technique for preserving side branches, especially septals, when doing an LAD CTO? And sometimes you see a nice CTO recolonization, but most septals have been shaved off. So I guess, Salman, you want to take that?
Those one. Ek how to preserve side branches. So septals preserve, I think it's plus minus. I think it would be ideal. The septal I'm most concerned about is usually the first septal. So if you have someone who has an RCA CTO and the first septal of RCA ko de raha hai, so that's the one you want to preserve. And the way I preserve any branch, be it the conus, the septal, or the diagonal branches, is to put a wire in there. Wire dal di aapne, it marks the branch, it marks कि कहाँ पे, even if you land a stent, you can use a jailed semi-inflated balloon technique to preserve it, but there are certain branches that need to be preserved, खासतौर पर जो diagonals आपकी हैं. Well, that's how you preserve branches. Sometimes that balloon can also help you by acting like a deflecting balloon to get you into the cap of the main branch. And जहाँ तक ताल्लुक है, you see these CTOs जहाँ पे all the branches are shaved. Sometimes people do subinterval tracking re-entry for an LED. वो पहले septal से शुरू होते हैं and then they re-enter close to the apex and they stent everything और हर diagonal भी बंद हो जाती है, हर septal भी बंद हो जाती है. I don't think that's a good technique. I think वो लेने के देने पड़ जाते हैं because while you're saving that apex, you've shaved off many more diagonals now. Septals फिर भी बच जाती है because oftentimes septals are collateralized by the PDA. They can lose a lot of diagonals. And those patients will often have more symptoms after, or it will be an unsuccessful CTO.
That's the issue with subinterval tracking. And
if I may add, Nasir, to this question of saving the side branches, I think before you start the procedure, by and large, you plan a procedure and you identify the vessels that need to be saved. And so you need to make sure that end of the procedure, or those identified vessels you've planned to save should be there. So
absolutely advanced planning and with subinterval tracking,
also,
really cautious not to shave
it's
off.
also that anybody who does a CTO should be able to do a good bifurcation also, because you'd end up with two large vessels and you should be able to handle that.
So, how frequently you undergo complete revascularization, including CTOs, especially RC CTO, in ACS and stable ischemic heart disease? इस पे पहले नदीम रिजवी साहब से भी discussion हो रही थी regarding achieving complete revascularization. I mean, we have all discussed CTO indication is primarily for symptom improvement and, may have some EFM advantage with the LED CTO, but, in terms of where you would want to achieve complete revascularization and then decision-making for preferring for surgery versus just keeping for PCI. So, Nadeem साहब से पहले discussion हो रही थी. So, your thoughts, Bashir साहब, and then Salman, your thoughts?
मैं इसी से related actually सलमान की जो slide थी जिसमें कि he has mentioned that several reasons for not doing CTOs, and I think all of us probably have given one or the other reason sometime to the patients especially in our setup and our economic conditions. A patient who is able to perform his activities of daily living or whatever he wants to do, he is able to do it without having chest pain. He may have some fatigue, जो हमारे तो हर patient को ही होती है, तो fatigue है या कुछ इस तरह से है, but no angina as such. And he has reasonably good collaterals, although I know you mentioned ischemia, collateral doesn't mean it's not ischemia, but if he's not having symptoms, or most of the time you are improving quality of life here, you are not changing the overall mortality in overall large context. So would you still be going for those CTO PCIs? I personally, a lot of time in a 70-year-old who is not having any angina and doing all those activities and reasonably good collaterals, I will leave them on medical management.
So, I mean, you're exactly lifestyle limiting symptoms hai, so you go for it and offer them that you may feel better and improve your quality of life.
Salman's slide was other ways, was pointing other ways that we should be considering.
That was a lot of registry data based on which he was, indicating that.
Yeah.
Salman, a question tha
Salman say something about it.
I think so. I think the point of that slide was that most people have lifestyle limiting dyspnea. So they're not these people who I could walk like 5 miles, now I can do 2 miles. I mean, that's a lot. एक दफा मुझे एक बंदा आया कि CTO के लिए कि I want to schedule it after my trip. मैंने कहा where you going? कहता I'm going mountain climbing in Colombia. मैंने कहा if you're going mountain climbing, you don't need your CTO fixed. So I think कुछ psyche भी हो जाती है कि patient को आप कहते हैं जी आपकी 100% artery बंद है और पेशेंट फिर परेशान हो जाता है, फिर हर सिम्टम में लगता है कि CTO से यहाँ सांस भी चढ़ रहा है, that kind of stuff. So I think there's a separate talk which again I would love to do about refractory angina and refractory ischemia. There are many therapies, medical therapy. A lot of these patients are often undertreated for medicine. So I think that's the first thing. अगर आप medical therapy हो, cardiac rehab करें, उन्हें encourage करें walk करने के लिए, because CTO में जल्दबाजी की जरूरत नहीं है, because it's not going to do something bad is going to happen in the next few days. And I think to your point, जहाँ पे resources properly आपने use करने हैं, if you do medical therapy, a lot of these patients will be able to enjoy life without needing a high-risk procedure.
So Salman, just to be specific on this question that this person asked Dr. Burhan, if you have a LED type A lesion, RCA CTO, so would you just open the LED and leave the RCA CTO alone? Because we have had this thing before the ischemia trial, you go for the difficult thing first. If you can't open it, then for complete revascularization, send them for surgery. So in the current scenario, would you just fix the LAD and say, "Ji, RCU, CTO रह गया, we can just treat it medically, अगर lifestyle limiting symptoms आते हैं, go for it." This is in chronic coronary syndrome stage, and also the question in acute coronary syndrome. दोनों scenarios, how would you approach this, situation?
So acute coronary syndrome is easier. If you have a STEMI or if you have someone with a critical lesion, जब तक surgeon आएगा और operating room में जाएगा, the patient having ischemia and infarct and muscle.
Non-STEMI की बात हो रही है, non-STEMI की, वो you can stage, वो तो STEMI तो is an easy one.
So, हाँ, exactly. So उसमें फिर again यही बात आ जाती है कि exactly residual anatomy क्या है. You see, if it's a relatively short, see, my CTO success rate for RC is pretty good now, I would say. Mashallah, I'm fortunate in that way कि हो गया. Lekin having said that, it doesn't always work. So what I would typically do is कि if I think the RC is doable, अंदाजा हो जाता है देख के, then I would probably offer both. Now, sometimes what we do is कि if the patient is diabetic and they're young at an age where they can benefit from bypass, then I will do BiFAT, because यहाँ पे obviously patients stay in the system. So if you know that the patient is going to stay in the system, and if you have a good surgeon and if the patient is not averse to surgery because of some cultural elements, then I would, because ultimately Lima ki value cannot be understated. I mean, Lima is probably better than any stent we'll ever have. So if Lima ki indication banti hai, to why not? Having said that, if the patient absolutely says ki surgery nahi karani maine, so then I would fix the LAD and that RCA, total occlusion. I mean, I typically, for stable patients, will not do the RCA first. I'll probably do the LAD first for a lot of different reasons. Like, and that's my style.
So the next question was when to go for the parallel wire technique while going for antegrade technique. You want to take that? And
so again, उसपे भी obviously मौका नहीं मिला talk करने का, but the parallel wire technique, original technique में तो ये था ना कि there were two wires going side by side. Now we have different dual lumen catheters, we have different wire techniques, different types. I think once you have a wire that you don't like a position, if you take that wire out, then you don't know exactly in the three-dimensional space what that wrong position is, and you end up going to the same place again and again, or hematoma ban jata hai. So if a wire is clearly in the wrong path and you're trying to redirect yourself, so then you take a second wire, or maybe variations aa jate hain. So today, for example, I had a case which was heavily calcified, or bar wire jo hai wo ek hi jagah pe ja rahi thi, and it was almost to the point of perforation. So we actually used a wire and then a balloon to block that piece of calcium so we could go around it on the other side. So again, parallel wiring technique is optimal for when a single wire is taking you to the wrong side of the vessel. Oftentimes it requires multiple views to confirm that. If you want to change your wire, but you also want to remind yourself where not to go, I think wahan pe karne ki zarurat hai. I mean, the guys in Japan who do it, just the way I do Carlino as my default technique, the people in Japan who do parallel wiring as their default technique.
So most common
add something here. We always talk parallel wire to direct us back into the lumen, but I think if you use a good parallel wire with another micro, I think it tends to break the proximal cap a little more if it's a stiff wire, and then it gives more support to the guider also. So it's not just getting the right track, it has its other advantages also. Right.
So the advantage of the parallel wire, basically it helps you change direction. So as Jan Sahab has said, कि कई दफा ये होता है कि cap is firm, but it's not firm, equally firm, or maybe it's firm on one side and it's directly into subintimal space. So whenever you go in, the wire will prolapse into that subintimal space. So you can block that or mark that with one wire and then use a wire with different properties to go around it. And because you're using different properties, key wire often gives you more support and acts like a stabilizing force for the guide. Absolutely.
So the next question was, what is the most common complication of Carlino technique? And my question on follow-up on that is, at what stage do you, an integrate wire escalation approach, actually use Carlino? I mean, I generally don't use Carlino. I just go with the wire. So what point do you switch over to Carlino once you start wiring? And the question from the audience was regarding the complications related to Carlino.
Okay. I am 100% Carlino. I'm 100% Carlino. So जब मैं पिछले एक साल से 100% and what I've learned over the years is that the sooner you do Carlino, the better it is, because if you wait too long to go into the cap, so you often do end up in places you don't want to be. So what now I do is I cross the cap, 1 millimeter, 2 millimeter. My fellows know, they all know Carlino ki mein technique kya hai. They're ready with the contrast range, because best case scenario mein is going to be it'll help you cross right away. Worst case scenario mein it'll show you what the plaque looks like. More importantly, it softens the plaque. आज का जो केस में दिखाना तो मैं नहीं दिखा सकता, वो जो दूसरे कंप्यूटर पे है, उसमें यही था कि we did a Carlino and you couldn't see anything except one side branch. लेकिन जब हमने wire pass की, the wire flew across that very long CTO, because Carlino just sort of makes that plain. So that's me personally. Now, having said that, complications में जो है ना, I think there's a virtual complication कि कई दफा Carlino का stain जो है ना वो बैठ जाता है plaque में. And for a lot of people, that looks like a perforation. It is not a perforation. In fact, वो stain जो है ना, now obviously we don't keep injecting it. We're talking about half a cc. तो वो adventitial staining जो है, which looks like a perforation, is merely to worry about that. So that's the virtual or complication. The other complication, which is not a complication, some people think it's a feature, जो पावर कार्लिनो है, जो हमारे अमेरिका में इसका कार्लिनो सिखाया जाता है कि you inject hard so that you get into the subintima ताकि you do subinterval tracking. So अमेरिका में it's a little bit more aggressive culture, the CTO culture है, so they don't believe in parallel wiring, they believe in either wire escalation, and wire escalation you usually do anterior dissection reentry. So there's a strong like stingray people who prefer the stingray. उसके लिए they use the carlino to go subintimal. Now to me that's sometimes the complication, because I'm trying not to go into the subintima. Lekin in my experience, Carlino has never caused a true perforation. Agar perforation hoti hai, to often it's a wire misadventure. You don't know where the wire is going. So
the last
Salman,
two
I have a
that
question.
will end because we've run over time. Ji Nadeem sir.
I have a question.
I just want to make one comment regarding microcatheters. देखिए, जिस तरह इन्होंने कहा ये कालिनो यूज करते हैं, I don't use microcatheters except in very bendy lesions where you see you need to एक microcatheter के साथ disadvantage ये है, for example I am a Gaia guy, तो Gaia and CP and maybe Fielder XT initially, तो जो आप you lose that feel of the thing और उसमें cost increment ज़्यादा हो जाती है. So in straightforward LEDs, I think where you don't need bends and where you can get a wire in, I think हमारे उसमें मैं तो I always use a bare wire and I only use a microcatheter. I think ये टेक्निक का है, जैसे सलमान ने कार्लिनो का कहा, तो मेरे ख्याल से लोकल अपनी एक्सपर्टीज आप करें और उसमें अगर कॉम्प्लिकेशंस नहीं हो रही तो there is no such thing as a default technique. I think techniques should be individualized and wires जो है उसके ऊपर प्रैक्टिस करना बहुत जरूरी है और वायर की फील जो है वो माइक्रो कैथेटर में इतनी अच्छी नहीं आती जितनी आपकी डायरेक्ट इन द वेसल अनप्रोटेक्टेड वेसल में आती.
So, I mean,
I may add to it. I mean, you individualize your treatment quite a lot, but you're probably the only guy who uses these stiff wires without a micro. And
yes,
of course,
I think
very, very nicely. And I really admire that, but that's not something which one would recommend for anybody.
Take cardiac CT ka role in CTOs, and what is your, if you don't have a string ray like in Pakistan, what is your method for re-entry once you've crossed the lesion, your subintimal, in the subintimal space, what is your re-entry approach generally? What wire do you use? What is your approach? So uske upar zara comment kar dete, and with that we'll wind up.
अच्छा ठीक है. So CTO comment छोड़ देंगे because I don't use a lot of CTOs. जापान में तो हर बंदा CTO के लिए CT के बाद ही आता है, but यहाँ पे I think अगर पहला CTO attempt fail हो जाए, then sometimes I'll do a CT just to see what am I dealing with. Having said that, with Carlino I get a feel for कि कहाँ पे बात है. Which I just want to address one thing that Nadeem said कि बिल्कुल everyone should use the techniques that they're more comfortable with, and I see a value to using just the wires because wire ka behavior and the wire feel becomes much more, because then the wire is interacting with the plaque throughout, not only at the tip. If a microcatheter ho na, to microcatheter is like power steering. हर wire की weight बढ़े, the feel of the shaft within the plaque. So उनकी बात बिल्कुल सही है कि अगर wire microcatheter ना हो, but again, it's a very skilled thing, and I think a lot of people shouldn't be using it without microcatheter. And the last question, re-entry techniques. I think उसमें जो है ना, फिर the slide I didn't get to show is कि जो different re-entry techniques हैं, आपकी जो है mini star technique है, जो distal cap fenestration re-entry है. There are some techniques you can use depending on the architecture. Parallel wiring उसमें आ जाती है. If you clearly in the subintimal space, and you can use a parallel wire to go in the other direction. Some people who have access to WhatsApp, देखो अगर नई तारीख खलील ने जो अभी केस किया था recently 2 दिन पहले, उसमें he basically used a confianza. So again, there are different techniques you can use, but inshallah, hopefully I'll be able to show some slides on that next time.
What about
but can be done
section?
Before I end this with the
if you have a soft wire, you will have a smaller dissection, and if you have a large stiff wire, you'll have a bigger dissection, and one should not twist this wire while you're dissecting.
Important point. So we'll end with, in Pakistan, we have limited resources and stuff. So for the panelists who are over here, what wires is using? I generally go with Fielder XT and Gaia 2 and CP12 for re-entry, and sometimes in between pilot wires, and then for microcatheters, it's super cross or fine cross catheters that what I use. And what is your inventory for all the other panelists? I just wanted quick comments on the inventory you have, and any reason specifically that why you prefer one over the other. So Elsa, what inventory do you have in terms of the wires and microcatheters?
We tend to approach the lesion with a run-through wire, which is our workhorse wire, and then we decide which wire to cross with. And if we can see the track and we have an idea, we were ambiguous, we tend to start with the pilot. And if it's of course a very high-grade J score, straight, then we go to a Gaia series, and we don't mind escalating straight up to second or third. And so that's bulk of the wires that we use.
Bashir Saab, your wires or microcatheter preferences?
Yeah, we have, again, our inventory in microcatheter is very limited. We have maybe a couple, but again, cost issue becomes a major issue. So the wires we have Confianza also and Gaia. So we again start with a regular wire, which sometimes could be even either run through or maybe just to have the feel with the BMW, and then we move to most of the time nowadays we move to Gaia wires.
And Zubair sir, any use similar wires, or you have some different? I have not used Gladius or Mongo over here. I don't know if it's available. It's a Salman likes that wire for extra plaque navigation and knuckling. But Zubair sir, any preference with your wires?
Yeah. First of all, as you have told, it's the same inventory, which is available in most of the centers of the Pakistan, where it's a Pilot 200 or Filter XT or this Gaia series or the Confianza, My choice obviously is to start with the usual wire with the balloon support, and if it doesn't work, obviously my selection of the wire depends upon the proximal cap of the CTO, whether it's a blunt or whether we would be able to. It's a tapered, If it's a tapered, I'll always select this Pilot 200 or Filter XT, or it's a blunt, I'll start with the Gaia series. Regarding microcatheters, obviously there is a super cross or fine cross will do, but Teleflex series, it's available, but it's a bit costly, So these are the usual equipment I use.
And for, as mentioned before by all the panelists and Salman as well, it's important to have, when you're doing these cases, it can result in complications when using aggressive wires, to have the pericardiocentesis kit ready in your room, and also covered stents and coils and whatever you need to seal off the perforation and deal with all the complications that you may come across. So should be a planned procedure, and not just doing ad hoc in any lab, as Bashir Saab pointed out as well. Should be done with proper planning and with proper backup equipment and the whole CTO toolkit there. So on that note, and with proper indications, after proper discussion with the patient. So on that note, thank you very much, everybody, for joining. It was a great session. I really enjoyed it and learned some tricks from Salman. So thank you again for joining and giving us a talk, and hope to keep you involved in future PSIC activities. So everyone have a nice week.
Thank you, Salman. It was a great talk. Loved having it.